It's funny. When you get a bad cut on your arm, you can kind of just watch the whole repair process happen right in front of you.
Right, yeah, it's right there on the surface.
Exactly. You get a scab, and then maybe some tight pink tissue, and eventually a fibrous scar. It's like this quick, messy patch job just to keep the outside world out.
Sealing the breach.
Yeah. And I think we all naturally assume that when we break a bone, a similar thing happens deep inside, like a bone scar, a patch over the crack. But we're doing a deep dive into the pathophysiology of fracture healing today, and the reality hidden inside your skeleton is fundamentally different.
It is entirely different. For the vast majority of human tissues, repair literally means laying down collagen-dense scar tissue, and that tissue never quite regains the original architecture or the original strength.
Right.
But bone is biologically unusual. When a bone heals fully, that segment eventually becomes histologically identical to bone that was never broken. I mean, it reconstructs an exact architectural replica of the original structure.
Which is wild.
Yeah.
It's the difference between patching a hole in drywall with duct tape versus completely rebuilding that section of the wall so perfectly that an inspector couldn't even tell there was a hole.
That's a perfect way to look at it. It's a complete regeneration, not just a repair.
But to understand how the body actually pulls off this reconstruction, we have to look past the most obvious part of treating a broken bone, which is the cast.
Right, the cast.
Because, you break your wrist, you go to the doctor, they put this heavy fiberglass cast on you. And the natural assumption is that the cast is somehow doing the healing.
Yeah.
But the cast itself is just passive, right? It does zero biological work.
Absolutely zero. A cast is simply external scaffolding. Its only job is to immobilize the limb so that the body's internal machinery isn't disrupted by, gross, unpredictable motion.
So it's just holding things still.
Exactly. The body is doing 100% of the heavy lifting. The cast just gives those cells a quiet room to work in.
Okay, let's unpack this. If the body is doing all the work inside that quiet room, the obvious question is how we actually know when the work is done.
Right. How do we define healed?
Yeah, you'd think healed is a simple binary like yes or no. But looking at the sources, clinicians actually use at least 3 overlapping thresholds to decide if a fracture is healed, and they don't seem to happen at all at the same time.
They rarely happen at the same time. The first threshold you usually hit is clinical union.
And what does that look like?
Well, this is what you, the patient, care about most. You can bear weight on the limb, you don't feel pain when you press on it, and when the doctor examines the limb, there is no abnormal wiggling at the fracture site.
So the bone feels solid from the outside.
Right. The pain is gone and it feels stable.
So clinical union sounds like feeling fine to drive, like the mechanic saying the car is fine to drive around the block.
Sure, yeah.
But then there's the second threshold, right? Radiographic union, which is when the x-rays actually showed new bone bridging the gap.
Exactly. But this is where it gets tricky.
Because an x-ray might look completely clean even if the bone isn't structurally back to normal.
Precisely. The x-ray shows us that a bridge has been built, but it doesn't tell us the structural integrity of the materials in that bridge. That requires the third threshold, which is biomechanical union.
Biomechanical union.
Yeah, this is when the bone has actually regained a defined percentage, usually around 80 to 90% of its pre-injury strength and load-bearing capacity.
Okay, so going back to the car analogy, radiographic union is the mechanic physically showing you the engine is patched up. But biomechanical union means the car isn't just patched up. The engine is finally ready for a grueling cross-country road trip.
That's spot on. And this raises an important question, right? Because the mismatch between these thresholds seems like a huge trap.
A trap for the patient, you mean?
Exactly.
Yeah.
A broken tibia could look solid on an x-ray and feel fine when you walk to the kitchen. But if you try to sprint a mile, it could fail because it hasn't reached biomechanical union yet.
Wow. So that's why orthopedic surgeons and physical therapists are always so annoying about staging a patient's return to activity.
They have to be. They know radiographic union lags behind true biomechanical strength. The internal architecture, it just takes much longer to organize than the external shape. The body works in phases, basically prioritizing immediate stability over ultimate strength.
And if the healing process is this fluid, defining failure must be incredibly difficult. I noticed in the clinical trial data from the sources that the FDA has a very strict definition for a non-union, meaning the bone has basically stopped healing.
Right.
They define it as a fracture, showing no progressive signs of healing for 3 consecutive months, measured at least 6 to 9 months post-injury. That seems so specific.
Well, the FDA needed to pin down a definition for legal and clinical trial purposes. Like, if you are testing a new bone-healing drug, you need a hard endpoint.
You need to know when to call it a failure.
Exactly. But biology doesn't carry a calendar. A bone doesn't look at a clock at the 6-month mark and decide to just give up.
Right, it doesn't know it's been 6 months.
No. The regulatory definition is just a compromise. The biological reality is that a fracture enters a non-union state whenever the physical or chemical environment prevents the cells from progressing to the next phase of reconstruction.
Okay, let's get into that reconstruction process.
Right.
Because if the cast isn't doing the work, I really want to understand what the cells are actually doing in the dark.
It's a fascinating process.
And our sources show that the body doesn't just have one standard operating procedure for this. There are two completely different mechanisms, and the body chooses which one to use based on how much the broken bone is moving.
Yeah, that's right. So the most common pathway, the one that happens in almost all fractures treated with casts, splints, or even just left alone in nature, is called secondary or indirect bone healing.
Secondary healing.
Yes. And this pathway expects and actually requires a little bit of physical motion to work properly. It unfolds as a continuous 4-stage construction project.
See, I always pictured bone healing as this slow, quiet calcification. But it actually starts with a massive, violent emergency response, right?
Very violent, biologically speaking.
When the bone breaks, it tears the blood vessels inside and around it, creating a large blood clot, or hematoma, in the gap. And I used to think a blood clot was just a physical plug to stop the bleeding, but it's acting as a chemical alarm system.
The hematoma is intensely active. The platelets and immune cells trapped in that blood clot start releasing a massive wave of cytokines and chemical messengers.
Playing the alarm.
Exactly. These signals flood the surrounding tissue, recruiting inflammatory cells and, crucially, pulling in mesenchymal stem cells from the bone marrow and the surrounding membrane.
So it's drafting workers to the construction site.
Yeah, and at this very early stage, like the first few days, the signaling is functionally indistinguishable from wound healing anywhere else in the body. The goal is just to flood the zone with raw materials and unspecialized workers.
But those unspecialized workers, the stem cells, they don't just start building hard bone right away. That seems like it would be the logical next step. But instead, they build cartilage.
They do.
Over the first few weeks, they form this rubbery matrix called a soft callus. And I really struggle to understand why the body wastes time building a weak, rubbery bridge when the ultimate goal is a rigid bone.
It comes down to structural survival. Think about it like this. If you try to build a rigid concrete bridge while an earthquake is happening, what happens to the wet concrete?
It'll just crack and fall apart.
Exactly. A fresh fracture is highly unstable. Every time the person shifts their weight or moves a muscle, the bone ends wiggle. Rigid bone-forming cells, osteoblasts, they just cannot survive or function in a high-motion environment.
Okay.
So the soft, rubbery cartilage callus is flexible enough to withstand that wiggling without breaking, while slowly stiffening the environment to stop the gross motion.
So it's acting like a shock absorber. It stops the two ends of the bone from flapping around so wildly.
Precisely. And once that rubbery callus stabilizes the fracture site, the environment is finally quiet enough for the heavy machinery to arrive. The body starts replacing that cartilage with woven bone.
And that's stage 3.
Right. This transition is a process called endochondral ossification. The body is essentially replaying the exact same process by which the fetal skeleton first formed in the womb.
Wow, that's incredible.
Yeah, the cartilage begins to calcify, and those osteoblasts invade, laying down disorganized woven bone. This creates a big, bulky lump around the fracture site. This is the hard callus.
Oh, so when you look at an x-ray of a healing bone a few months in, this is the classic fluffy-looking cloud you see wrapping around the break.
That's the hard callus, exactly. It's
Yeah.
much stronger than the rubbery soft callus, but it's still disorganized. It's bulky.
Right, which leads to the final phase, remodeling, which the sources say can take months or even years.
Years, easily.
The body brings in osteoclasts, which are basically microscopic demolition crews that secrete acid and enzymes to dissolve the bulky, excess woven bone.
And trailing right behind them are the osteoblasts, laying down highly organized, dense lamellar bone.
So over years, that bulky, fluffy callus shrinks away, the hollow canal at the center of the bone reforms, and the internal architecture aligns itself perfectly with the daily loads the person experiences.
Remarkably, yes. Especially in young children, a bone that healed slightly crooked during the callus phase can actually straighten itself out entirely as it remodels around the new physical forces of walking and running.
That is just mind-blowing. So that entire cascade, the blood clot, the rubber bridge, the bulky woven lump, and the years of remodeling, that is secondary healing.
Yes.
But the sources outline a second pathway, primary or direct bone healing.
Primary healing is almost entirely a product of modern medicine. It occurs only when a surgeon intervenes to physically reduce the fracture to near-perfect anatomical alignment and then locks it down with absolute rigidity.
We're talking heavy compression plates and metal screws here.
Exactly. The environment has near zero strain, zero motion. And under these highly specific conditions, the body completely skips the soft and hard callus phases. There is no fluffy lump on the X-ray.
Not at all.
None. Instead, you get these highly specialized structures called cutting cones. Since there is no gap to bridge, these cutting cones literally drill right across the microscopic fracture line, like tiny tunnel boring machines.
Wait, really? Like microscopic mining machines?
Yeah. The demolition cells, the osteoclasts, are at the front, eating away a tiny tunnel through the dead bone. Trailing right behind them in the same tunnel are the osteoblasts, laying down brand new, highly organized bone cylinders directly across the crack, welding the two pieces together.
But if primary healing perfectly welds the bone back together with these tiny microscopic mining machines, the cutting cones, why doesn't the body just do that every time? Why bother with the bulky, messy callus phase at all?
It seems inefficient, but primary healing has severe physiological limitations.
Like what?
First, it is a very slow process to regain full mechanical strength across the entire bone compared to the rapid stabilization provided by a bulky callus. The callus acts like a massive internal splint.
Right, and primary healing doesn't have that splint.
Exactly. But more importantly, primary healing requires absolute microscopic perfection. The alignment must be flawless, and the fixation must remain completely rigid.
And in nature, absolute zero motion is impossible. You have to run from predators or forage for food.
Exactly. If there is even a tiny gap or a slight bending motion, the cutting cones simply cannot cross the void. When a cutting cone hits a gap or excessive motion, primary healing fails.
Well, what happens then?
The body abruptly tries to revert to secondary healing to bridge the gap. But in a surgically compressed environment filled with metal plates, that secondary response often becomes disordered, leading straight into a non-union.
I see.
The body relies on the messy callus in nature because it's the most robust, fail-safe way to bridge a gap in a chaotic, moving world.
So how the body actually senses its environment, to choose between the chaotic world of the callus or the rigid world of cutting cones, brings us to the physics of healing.
Physics plays a huge role here.
Yeah, and the foundation of this traces back to a massive conceptual leap in 1892 by a German anatomist named Julius Wolff.
Ah, Wolff's law. Before Wolff, scientists observed the stages of the callus, but they didn't understand the physical rules governing it. Wolff published what we now call Wolff's law, which states that bone adapts its internal architecture and its external shape to the mechanical loads placed upon it.
So form follows function on a cellular level.
Precisely. If you lift heavy weights, the physical load signals the osteoblasts to lay down more minerals, making the bone denser.
And if you have a paralyzed limb or spend 6 months in a hospital bed experiencing no load.
The osteoclasts take over and the bone physically wastes away.
Okay, so Wolff's law established that bone cells are exquisitely sensitive to mechanical demand. But it wasn't until the 1970s that a Swiss engineer and physician named Stefan Perrin applied this to the microscopic environment of fracture.
Yes, Perrin formulated the interfragmentary strain theory. He wanted to understand why certain tissues form in the fracture gap and why others die.
Right. He figured out that different tissues can only survive if the microscopic stretching the physical strain across the fracture gap stays below a certain limit. Because when you break a bone, every time you move, the gap stretches and compresses.
Exactly. And Perrin showed that the initial granulation tissue, the blood clot phase, is highly elastic. It can tolerate massive strain around 100% deformation.
Meaning it can stretch to double its length and the cells survive?
Yes, but cartilage is stiffer. It can only tolerate about 10 to 15% strain, and mature, dense lamellar bone. It can tolerate almost no strain, maybe 2%, before it physically cracks.
So if we look at this, the granulation tissue is like a highly elastic bungee cord. The cartilage is a stiff rubber band, and the lamellar bone is like a steel beam.
I love that analogy.
The body builds the bungee cord first, simply because it's the only material elastic enough to survive the initial violent wobbling of a fresh break.
Right.
The bungee cord stabilizes things just enough for the rubber band to survive without snapping. And then the rubber band stabilizes things just enough so the steel beam can be built without cracking. The body slowly upgrades the material as the wobbling stops.
That's a great way to visualize it. And if we connect this to the bigger picture, Perrin's strain theory completely revolutionized modern orthopedics.
How so?
Well, in the early 20th century, surgeons believed that complete rest and absolute zero motion was always best for healing. They practiced compression osteosynthesis, using incredibly stiff, massive metal plates to lock the bone down.
Trying to force primary healing.
Exactly. But they found some of these rigidly fixed fractures simply refused to heal, and the bone around them grew weaker.
Because of stress shielding, right. The stiff metal plate was carrying 100% of the mechanical load. The underlying bone felt no strain, no physical demand at all.
Exactly. Wolff's law kicked in, the bone cells sensed no mechanical need to exist, and the bone literally atrophied and dissolved right underneath the heavy metal plate.
That is wild.
The failure of absolute rigidity led to a massive shift toward biological flexible fixation. Modern surgeons frequently use intramedullary nails, titanium rods placed inside the hollow canal of the bone, or slightly more flexible plates.
To purposely preserve a tiny bit of controlled micromotion.
Yes. They trade a fraction of initial rigidity to purposely stimulate that secondary rubbery callus formation, utilizing Perrin's strain theory to get faster, more robust biological healing.
It's an incredibly evolved, step-by-step system of physics and biology. But because it requires this perfect cascade of motion, strain, and cellular timing, there are countless places for things to go wrong.
Oh, absolutely.
For any of this to work, whether it's the messy callus or the precise cutting cones, these cells need massive amounts of energy and raw materials. They can't build bone out of nothing. The entire cascade completely depends on angiogenesis, right?
Yes, the growth of new blood vessels into the fracture site. Bone-forming cells cannot survive without a robust, continuous blood supply. If angiogenesis fails, the healing process stops immediately.
And the sources highlight a really dramatic textbook example of this vulnerability. It happens in a tiny peanut-shaped bone in your wrist called the scaphoid.
Yes, the scaphoid is notorious.
It sits right at the base of the thumb, and it acts almost like a ball bearing for the wrist joint, meaning a huge portion of its surface is covered in smooth articular cartilage. And blood vessels cannot penetrate through cartilage.
Right. Because of that cartilage coverage, the scaphoid has a severe evolutionary quirk. Its blood supply can only enter through a small non-cartilage strip at the far end, the distal pole.
The far end.
Yeah, so the blood then has to flow backward or retrograde toward the proximal pole, which is the part closer to your forearm.
Oh, man. So if you suffer a fracture right across the waist of the scaphoid, you essentially sever the only highway delivering blood to that proximal half.
It's a dead-end street. The proximal half of the bone is suddenly cut off from all oxygen and nutrients. Because of this retrograde flow, the non-union rates for a scaphoid fracture can shoot up to 30 or 40% if it's not treated perfectly.
The bone cells just starve to death.
Yes. And they are notoriously tricky to spot on early x-rays. You fall, catch yourself with your hands, your wrist hurts, but the x-ray looks completely normal.
But a good doctor will still put you in a splint, right?
Exactly. They'll tell you to come back in 2 weeks because they know how dangerous cutting off that specific blood supply can be.
This critical need for a continuous blood supply is also the physiological reason doctors are so adamant about warning patients not to smoke while healing.
Nicotine is a potent vasoconstrictor. It literally shrinks the diameter of small blood vessels.
It's counterintuitive for a lot of patients. You think, I'm smoking, that damages my lungs, what does it have to do with my broken leg?
Right, but that nicotine travels through your bloodstream, constricts the microscopic vessels trying to feed the fracture site, stalls the angiogenesis process, and chokes off the supply lines to the bone-forming cells.
Brutal. And alongside blood supply, there are chemical controversies that can throw a wrench in the gears. One heavily debated topic in orthopedics involves NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen.
Yes, this is a big one.
Because we know that the very first hematoma stage relies on a massive wave of inflammatory signals to recruit stem cells. So some laboratory research in the sources suggests that aggressively suppressing that initial inflammation with NSAIDs might blunt the chemical alarm system.
Potentially slowing down healing or increasing the risk of a non-union? The clinical data in humans is mixed, to be fair, but it's a live debate that actively shapes how emergency room doctors prescribe pain relief today.
Here's where it gets really interesting, though. The most fascinating chemical story in the sources revolves around a product called Indiferia, or RHBMP2.
Ah, yes. bone morphogenetic proteins.
Right, these are the natural growth factors the body uses to signal stem cells to turn into bone-building cells. And in 2002, the FDA approved a concentrated, lab-made dose of this exact protein. The idea was to implant it during surgery to supercharge healing for difficult spinal fusions or severe fractures.
From a purely mechanistic standpoint, it seemed completely logical. If the body uses this specific chemical to build bone, dropping a massive concentrated dose of it into a fracture should logically create a massive, rapid bone healing response.
But looking at the clinical outcomes, there was a severe backlash. Wait, so we found the exact natural growth factor the body uses to build bone, gave the body more of it, and it backfired. It sounded like we tried to shout instructions at the cells instead of letting them have a conversation.
That's a brilliant way to phrase it. The mechanistic logic failed because it ignored the natural spatial and temporal regulation required in biology.
Meaning the body relies on strict timing.
Exactly. The body precisely controls when and where these proteins are released. By dropping an unregulated bolus of BMP into the tissue, it triggered a condition called heterotopic ossification.
Which means what exactly?
The stem cells were so overstimulated that the body started rapidly forming bone in places it absolutely shouldn't be, inside the surrounding soft tissues, muscles, and nerves.
Oh, wow.
It caused severe, sometimes life-threatening inflammatory swelling. It remains a major cautionary tale about respecting the delicate timing of the body's chemical signals.
However, when medicine actually works with the body's natural systems rather than trying to override them, the results are incredible. Understanding the callus pathway has allowed surgeons to literally hack the skeleton. Just look at the Elizarov method, also known as distraction osteogenesis.
The Elizarov method is a masterclass in manipulating parent strain theory. It was developed in the 1950s by Gavril Elizarov, a Soviet surgeon working in Siberia with very limited resources.
And what did he figure out?
He discovered that if you surgically cut a healthy bone and then use an external metal frame to slowly, mechanically pull the two ends apart at a highly specific rate, exactly 1 millimeter per day, the body's secondary healing machinery will just keep filling the widening gap with brand new bone.
Wait, 1 millimeter a day and the construction crew never stops.
It never stops. The body senses the tension, builds the soft callus, but because the gap keeps widening at a controlled rate, the tissue never fully stabilizes into hard bone until the surgeon stops pulling.
That is amazing. It proves that the fracture healing cascade isn't just an emergency one-off patch job. It is a general-purpose, continuously running bone-building program that we can manipulate to lengthen limbs or replace massive chunks of missing bone caused by trauma or tumors.
It's truly revolutionary, but, that same natural remodeling program can be overwhelmed if the mechanics outpace the biology. That is the physiological reality of a stress fracture, which we see constantly in military recruits during basic training or in endurance athletes.
Right, because a stress fracture isn't a single traumatic snap. It's a biological race that the body is losing.
Exactly.
Repetitive pounding, like running 10 miles a day in heavy boots, causes microscopic cracks in the bone matrix. Wolff's law kicks in, the osteoclasts arrive to clean up the microdamage, and the osteoblasts try to rebuild it stronger.
But if the athlete keeps pounding on the bone without resting, they are creating new microdamage faster than the slow-moving osteoblasts can lay down new minerals.
The healing biology is simply outpaced by the rate of re-injury, and eventually, the weakened bone gives way.
What's fascinating here is the fundamental link uniting all of this. Wolff's law, stress fractures, the Elizarov method. It all comes back to the question of how the bone cells physically sense these mechanical loads.
Yeah, how does an osteoblast actually know that a bone is bending?
It comes down to a phenomenon discovered in the 1950s by Japanese researchers Fukada and Yasuda, the piezoelectric effect in bone.
Meaning bone literally generates its own electricity.
Yes. Bone isn't just dry chalk. It's a composite material made of flexible collagen fibers embedded with rigid hydroxyapatite crystals.
Okay, so when you put mechanical stress on a bone, like when you run and the bone bends slightly, that structural deformation physically squeezes the crystal lattice.
Exactly. And this mechanical squeezing displaces electrons, generating a tiny microvoltage across the fracture site.
So the physical force translates directly into an electrical signal.
Yes. That tiny electrical charge acts as a cellular beacon, directing the bone-forming cells to the exact sites of mechanical load. This explains the physical mechanism behind Wolff's law.
Oh, I see.
And it's precisely why modern orthopedics uses bone growth stimulators, devices that emit low-intensity pulsed ultrasound or electromagnetic fields to try to jumpstart stubborn non-unions.
By artificially recreating those electrical signals, they trick the cells into thinking the bone is experiencing healthy mechanical strain.
Exactly. It's a closed loop.
The mechanical load creates the electricity which directs the biology, which builds the structural architecture. And this completely debunks a huge misconception that a lot of people have,
Yeah.
that a healed bone is permanently weaker.
Totally false.
Right, during that early bulky callus phase, yes, it's weaker. But after full remodeling, which we know takes years, that bone is just as strong, and sometimes locally even stronger than it was before, precisely because Wolff's law has reinforced the new architecture based on the electrical signals of daily loading.
The necessity of that daily loading is why getting patients moving immediately is so critical to survival. We see the darkest side of this requirement with geriatric hip fractures.
How so?
Well, in elderly patients, poor biological healing potential combined with prolonged immobility leads to a massive, well-documented spike in one-year mortality. Their bodies simply cannot survive being bedridden. The bones atrophy, the lungs weaken.
So rapid surgical fixation of a hip fracture isn't just about fixing the bone.
No, it's about making the bone rigid enough to get them upright and moving again so the biological systems driven by mechanical load can keep the patient alive.
Wow. Let's wrap up this deep dive and consolidate the major takeaways for everyone listening.
Sounds good.
First, bone regenerates rather than just scars, and it's capable of rebuilding an identical replica of its pre-injury self. Second, there's a delicate dance between secondary healing with its chaotic, brilliant callus and primary healing, which uses microscopic cutting cones but requires absolute surgical zero strain.
Right.
Third, Perrin's strain theory dictates the materials. The body builds the elastic bungee cord before it builds the rigid steel beam. Fourth, an X-ray showing a bridged bone does not mean the bone has regained its true biomechanical strength.
A very important distinction.
And finally, mechanics and electricity guide the cells, but a continuous blood supply is the ultimate decider of fate. Just look at the retrograde flow of the scaphoid bone.
The entire pathophysiology of fracture healing is a masterclass in cellular adaptation. It is a system perfectly tuned to utilize the mechanical strain, the physical motion, and the gravity of life on Earth.
Which leaves me with one final thought for you to ponder based on these mechanisms. We know from Wolff's law and the piezoelectric effect that bone absolutely requires mechanical load and the force of gravity to squeeze those crystals and generate the electrical signals that tell the cells where to rebuild.
It's mandatory.
So what happens if we become an interplanetary species? If an astronaut suffers a major complex bone fracture on a multi-year zero-gravity trip to Mars, without the mechanical strain and the gravity needed to generate those electrical beacons, will the bone ever truly heal at all?